Good morning, one and all. My name is Dr. S Rahul, and my topic for PG Symposium today is awake craniotomy challenges for neuroanesthesiologists. And I would like to thank the organizers for giving me the opportunity and Dr. GB Singh for mentoring me with this session. Thank you. So as we begin, why we keep awake? We keep awake when the surgery is being done around the eloquent areas, or when one needs to identify or resect an epileptic foci, and definitely to eventually to minimize the overall morbidity and ICU stay and hospital stay. And these are the eloquent areas around which, when the surgery is being planned, we try to facilitate an awake craniotomy. And the certain indications, there are multiple of them, but for the purpose of this discussion, epilepsy surgeries and lesions around the eloquent areas form the bulk of the surgeries where awake craniotomies are performed. How one can avoid challenges or hassles is with a proper patient selection and trying to ensure that whoever is being selected, it is in indication and not trying to stretch too far. Sometimes, as I said, the reason why knowing the surgeon is important is sometimes a young, an upcoming neurosurgeon, for example, they might have a point to prove, and sometimes one can become slightly overfetch or try to go a little slightly overboard and select a wrong patient or a lesion which is much big and which is not congenial for an awake craniotomy. Definitely identifying and addressing the psychological aspects, not missing things preoperatively, ensuring that the scans are thoroughly reviewed, and ensuring that the surgical duration is definitely, we need to know about the surgical duration to ensure our anesthesia planning. And coming to challenges, the challenges can be broadly divided into an anesthesia related and the complication related. Over the next couple of slides, I'm going to discuss individually each of them. So anesthesia-related factors, as spoken, the patient selection becomes paramount importance. Why? Because as we know that we need a patient's contribution in this awake craniotomy maybe is as good as a surgeon's contribution in this. A good, properly compliant patient can go a far way in as far as improving the outcomes as well. So one needs to identify the proper patient selection, ensuring the psychological aspects are addressed, the phobias are addressed. The surgery itself is something patients are worried and apprehensive about. On top of that, when they know that the brain is going to be open and they're going to be awake, that adds to it that much more. So an effective pre-op communication and always saying no by knowing the contraindications as to avoid. I'm not going into detail, but one thing we need to keep in mind is, especially in obese patients, patients with OSA, patients who cannot lie supine, especially patients with the NYHA type 4 or shortness of breath or orthopnea, that is something which we need to know preoperatively to ensure that the patient is at least able to lie down supine without having to hyperventilate or get dyspneic. And definitely in uncooperative patients, slight mentally, not exactly mentally retarded, but I would say patients who are anxiety, type A personalities, we might be able to identify them pre-op and kind of preempt that if they are the rightful candidates or not. That with a big lesion, that with a lesion in a tricky area is something which one needs to keep in consideration. Then a pre-op evaluation, again, not going into too much of detail because our topic is entirely different, but the few things like ensuring that the language barriers are addressed, anxieties are addressed. Language barriers becomes very important in an institute like ours, where people come from all over the country with who some of them speak only their local language. That can be a huge challenge as far as communicating with the patient is concerned. We always not find translators for them. That is to be taken. Like, for example, once we had a patient from Manipur who only spoke Manipuri. So we ensured that we identified a nursing staff who was from Manipur, and we ensured that she stayed inside the OT. These things may have to be done. And other things like ensuring that the patients are on, if they're already on AEDs, ensuring that they're taking their anti-epileptic medication till the day of surgery. Extremes of age, seizures and type, number, frequency, and the medications are receiving, if available, plasma levels. And of course, as I said, a thorough preoperative airway evaluation, because this is going to be a tricky airway with the head pins fixed. And psychological concerns, as I said, are often underestimated. It definitely improves the patient's overall experience and satisfaction with the surgery. And yes, preoperative meetings, sometimes even multiple, and sometimes as a team, where the surgeon, anesthetist, and then the neurophysiologist may all need to go together and meet as a team, and multiple meets are set to build a better rapport. And definitely a well-informed and a cooperative patient is what we need, because that is almost half the battle won. So addressing psychological concerns, we believe, is almost half the battle won. Then coming to the consultation do's and don'ts, there are certain things which, especially in the preoperative counseling session, it's very important that we give honest information and avoiding too much or too little. Sometimes we tend to give too much of information and unnecessarily scare them. At the same time, we shouldn't even brush things aside and they get shocked in the OT all of a sudden. And tailoring the information is very important, and avoiding opportunity to ask questions, and making it rather elaborate one, and trying to avoid too little or too hurried explanation, and definitely misinformation should be kept aside. And anesthesia planning is to be anesthesia planning. There are multiple ways, multiple techniques that have been prescribed. We need to have a clear-cut institutionalized protocol beforehand to avoid unwarranted outcomes, unwarranted challenges. So after the advent of Dexmed, almost as far as the awake craniotomy is concerned, where we keep the patient sedated throughout. So why it is important to ensure a targeted conscious sedation to say a BIS monitoring or an entropy is to avoid unwarranted over or under sedation, because both of them can add to our problems. So as said, knowing the targets, even clinically, one can keep it as a MOAS score 3, which is a modified observer's assessment of alertness and sedation, where we need to keep the patient to a sedation level where he is easily arousable with loud noises. You call out the patient's name and he should be able to respond, and he should be arousable is the thing. Of course, it's definitely great if you can have BIS and entropy in the institute. It's always good to target a good BIS value in the upper range of 50, in the upper range especially. So to know how to keep the patient and how deep is very, very important. As said, multiple drugs have been prescribed, not going into too much of details, but Dexmed, Ketofol, Propofol are some of the widely used ones in awake craniotomy. Then knowing the scalp block is very, very important, because there's some sort of maybe a cornerstone in awake craniotomy. Because as we know that a good awake craniotomy is purely sometimes based on a good scalp block. If the scalp block is good, the patient is pain-free, the patient is comfortable, the patient is compliant, and the surgery goes in a rather smooth direction. So there's no harm in calling it a cornerstone. And definitely knowing the anatomy is of great help. And we might also have to know the upper thresholds of the drug doses. Why? Because both the sides, multiple nerves, and us and surgeons, everybody is giving. So we need to ensure that the doses are kept in check and planned accordingly, that the surgery or the duration of the block should at least come to 6 to 8 hours, because the surgery can go for that long. And yes, the pins are also on the opposite side. It's not only about giving a good block in the side of surgery, but also on the opposite side, because there is a pin, there's a little pin lying on the outside as well. And ultrasound techniques have been proposed, which are known to lower the drug requirements and vascular invasion. So as said, knowing the anatomy and a good scalp block and a good efficient scalp block is of great aid. And almost half the challenges are prevented if the patient is pain-free. So as said, there are a few adjuvants which are prescribed, which are said to reduce the overall dosages of the local anesthetic, like the dexamethasone and Maxelf have been tried, which can be used as well. And then patient comfort and compliance, as said, a nice and warm, noise-free OT with a nicely comfortably lying patient, avoiding extreme neck positions, ensuring that the extremities are well padded, he's not painful. We need to ensure that the alarms are set as well. Many a times we forget to set the alarms. Alarms have to be set to ensure there's unwarranted honking, and because already the patient is anxious, apprehensive, and the unwanted blaring horns might make it all the more difficult. And ensuring and coordinating the surgeon the various painful procedures to ensure that the anesthetist is, the technique is given, and sometimes even they might have to be told the patient is awake. And ensuring that the face is visible, approachable all the time is very, very important. And the drapes have to be tilted away from the face as well. But this is the most paramount important. The face has to be visible and approachable, because as we know, this is a difficult airway scenario if it gets to that. So we need to have an access to the patient, and most importantly, the face has to be visible. If he's drooling, if he's having secretions, if he's snoring, everything has to be visible right in front of our eyes. Then this is how we try to keep the tents away from the patient. And sometimes we might have to just cover the eyes just to facilitate him to sleep. Again, this is based on patient's request sometimes. And we ensure that the patient's face is always visible and accessible from all places. In the position as said, this is how the anesthetist and the machine is. So there has to be some place to reach the patient's face. So some non-verbal techniques, some non-pharmacological techniques to ensure that the patient is calm and comfortable is to continuously have a verbal and eye contact, holding hands. Holding hands can go really, really far away in assuring them that they are fine, that they're in good hands. Refraining from unwanted noises in the OR, unwanted people in the OT. Sometimes a light music can be of great help, and telling them that they're doing great, and ensuring them, and sometimes even giving them a heads up before, say, a bone is being drilled, or before there is some anticipated pain. We might have to tell them beforehand, you might experience some amount of pain or some amount of discomfort, or you might hear some pressure or some noise. That also can definitely be of great help. And yes, ice chips and cold cloths have to be kept all the time to ensure that their tongue and lips are not dried. Then, of course, these are, as mentioned already, we need to know at when to taper sedation, when to keep a sedation at a higher level. As I said, the initial phase of the surgery, where the sedation requirement and the analgesia requirement is slightly higher than when after the dura is open, when the testing and surgical intervention is being done. As said, there we might need little to no sedation required at that point. And closure of, and just before closure, we might again need some more pain as well. Coming to the anticipation and management of interop complications. As said, there are airway-related challenges can be quite dreaded and sometimes extremely challenging to manage, especially considering the fact that the patient's head is fixed to a pin and head is not accessible many times. And sometimes, to make things even worse, the brain is already exposed and you do not want to lose an airway at that point where it is difficult to bring him off pins. So as said, the head, inaccessible head, exposed cranial contents, and hypoxia, desaturation, all these sort of things can have immense amount of effect. And sometimes the over sedation has to be definitely suspected and titrated accordingly. So always, as I said, the troubleshooting of an airway situation starts with preoperative beforehand. Preemptive preparation is the key. That the airway card has to be fully functional with all video laryngoscope, fiber optic, whatever is available, has to be kept. But most importantly, the most of the times, we need to try to awaken the patient, give a good jaw thrust, and if possible, most of the times a well-fitted nasopharyngeal airway, which has to be calculated beforehand, and not to run around and look for the right sizes at that time of a calamity. It's always good to identify one nasopharyngeal airway and mark it and keep. And if needed, a nasopharyngeal airway many times we'll try to avoid most of the times even intubating or even putting an LMA for that matter. So an identified and however LMA, and if needed, try to intubate him after removing the drapes of the face and even the frame for that matter. So as said, there are two different ways an airway can go wrong. The patient can have a respiratory depression because of oversedation, or they can have obstruction. The patient has just vomited, or patient through a seizure, or patient is patient of OSA. So all these are possible. So interop seizures, as said, more often are focal, self-limiting. We find them more often than not. But the problem happens when they become uncontrollable. So much so with an exposed brain, it becomes extremely catastrophic. So an ice cold saline, ease of bandation, not just from surgery side, from our side as well. We need to time and again give them heads up and even inform the nurse and the nurse anesthetist beforehand that ice cold saline be kept ready, be available, and also tell them that this is what we are anticipating and this is what you need to do in that particular time. And definitely preoperatively, we have to optimize and ensure that the anti-epileptic medications are being taken. In our institute per se, we tend to give repeat dose even on the day of surgery. And we might have to even repeat as well. But ice cold saline, as I said, can be of paramount importance, especially when there's there is some amount of focal movement after a particular point of the brain is stimulated. We inform the surgeon and they flood the field immediately with ice cold saline, and they will try to avoid it. Usually, most of the times, they try to avoid re-stimulating it. But the challenge happens if it happens multiple times. We might sometimes even have to go for conversion into GA as well. If it becomes extremely difficult to manage by just ice cold flooding, we might even have to go for a complete GA as well. So as I said, notify surgery immediately, immediate withdrawal of stimulation, ice cold saline, or RL, cold RL if it's available. Small profile boluses preventing re-stimulation and GA conversion if needed. So tight brain is again a very big issue one can face because we are not able to monitor ETCO2 that well. And PaCO2 is not readily available in a dynamic way. So definitely an underlying Marsley effect. On top of it, there is hypercapnia because the patient is sedated and patient is not clearing out CO2 that well. There can be some amount of hypercapnia which is adding to it. So as a reason, there can be some tight brain affected where one needs to verify the patient's position, administer challenge osmotic agents, and sometimes even might have to reduce sedation. Sometimes an over sedation itself can be a big cause for tight brain as well. So informing the surgeon and being in constant communication is of great importance to identify tight brain, because we don't want a fully tight brain and only then we start doing things. We can actually start it as a preemptively. We can probably reduce sedation, ensure that the patient is in good position as well. And role of mannitol, in our institute, we are giving mannitol as a routine, but widely it is believed, the moderators can throw some light, that mannitol, they say, is better as a rescue drug than preemptively give. There could be some conflict on that, but there is no clear-cut evidence as to routinely prescribe mannitol. Of course, we are giving, and many institutes I know are giving, but there's no clear-cut mandation in who gets mannitol or not. We can have a discussion on that, I believe. Then coming to nausea and vomiting, yes, it's always better prevented than treated. It might look relatively normal thing to happen, nausea, vomiting, but in a patient who's already sedated, it can be quite dreading. Especially there are risks of the patient can lose his compliance. They might stop cooperating, and there is definitely a huge risk of aspirating, airway obstruction, and definitely all this can cause brain bulge, hypercapnia. All sorts of unwarranted things can happen with a simple nausea and vomiting, which can be prevented. So as a rule in our institute, when the patient walks in, we attach monitors, we place line, we take the basal vitals, and the first thing we give most of the times is an MSIT. The simple MSIT, sometimes a prophylactic antiemetic, can go far away, and we try to avoid excessive narcotic, because we are always giving, most of the time we're using dexmedetomidine, that itself reduces unwarranted opioid excess in general. And definitely reassurance and sometimes rescue antiemetics and low dose propofol also helps in nausea and vomiting. Then coming to hemodynamic instability, all combinations are possible as expected in any of the surgeries. But what we need to cater to is the pain, anxiety, hypovolemia, sedation overdose. All these factors might have severe hemodynamic perturbations, like a lot of pain, a lot of anxiety, hypovolemia. They can be tachycardia, hypertension, sedation overdose, dexmed. They can be bradycardia, trigeminal cardiac reflex, bradycardia. These things have to be also to be kept in mind. I'm not going into detail because of the short of time, but we have to ensure that that there is good amount of analgesia during the rate limiting steps or the initial steps, not the rate limiting, the initial steps where there is pain expected. There we ensure adequate analgesic sedation, and we have to look for blood loss anticipation as well, because the patient, because the surgeon is in a hurry to finish off the surgery, so there could be a risk that the hemostasis is not effective. So we have to anticipate the blood loss as well. And always one needs to keep in mind, in an awake craniotomy, sudden drop in blood pressure, always VA has to be kept in mind as well. So talking of VAE, which can be of quite dreaded, not because of the air, but because of the fact that we might miss the diagnosis on time in an awake patient, because we do not have the usual ETCO2 monitoring, and also the TE is not possible. So we may be able to miss a diagnosis more often than not, because the patient is head up, patient is awake, and they're spontaneously breathing. So there's a lot of negative intrathoracic pressure which is building up, which can kind of cause the air to enter. So we have to prevent hypovolemia. We have to ensure that they are pain-free, they're comfortable, because pain, agitation, everything can cause hyperventilation, and that itself can be a risk factor for venous entrainment. There are a few case series which has been done by a couple of isolated case series. What they have found is, in patients who are awake, who are subjected to venous air embolism, they tend to have a tachypnea, sudden bouts of coughing, chest pain, and suddenly a comfortable cooperative patient becomes restless and agitated. So whenever in our patients in awake craniotomy, suddenly these things are found, always it is better to inform the surgeon, because this could be a venous air embolism presenting as tachypnea, cough, chest pain, and restless, agitating, and uncooperative patient. Because as we see in intubated patients, it's kind of clear cut. When we see there's a drop in ETCO2, sometimes there's hypoxia, ECG changes, but these may not always be translated in awake. So it's always good that watch out for unexplained hypotension with cough, tachypnea, and chest pain. Look for venous embolism, and may even have to intimate the surgeon as well. So just finishing off in last couple of slides. So these are the complications which we discussed about, and these are the biggest challenges that one anesthetist face. But the take-home points I would like to say are that every institute needs a sound, evidence-based institutional protocol is of paramount importance in AV craniotomy, and emphasis has to be kept on pre-op counseling, psychological support, and the face needs to be visible all the times inside the OT. And thorough airway preparedness, no matter how cooperative the patient and how seemingly uneventful the surgery might seem, perhaps. Now, targeted monitored sedation to ensure that there is no over or under sedation, and ensuring that the patient is comfortable is almost a good compliant patient is almost half the battle won, and never ignore a coughing patient. Thank you.